Good afternoon, everyone. My name is Juan Andino. Thank you for being here for this lunch and learn, so to speak. I'm really excited to be talking to you all about the Therapy Awareness Program, erectile dysfunction, ED, and the treatment options. And let me just go through some background slides and a little disclaimer, and hopefully we can just jump into the content. For the sake of the rest of the presentation, please feel free to use the chat feature and send any questions that you may have my way through the chat feature. I'll address any of those that you have, and if any more pop up at the end of our talk today. And so just to give everybody a backdrop and some additional information, I'm going to start with telling you a little bit about myself. Then we'll go over an overview of erectile dysfunction. What are the different causes or contributors to ED? Why do I think, and many other experts think, that it's important to actually inquire or ask patients about erectile dysfunction? And then we'll jump into what I do a lot of the time here, both at UCLA and at Martin Luther King Hospital, is what are the treatment options, what are the success rates, and how do I talk to patients about erectile dysfunction? So like I said, I'm Dr. Juan Andino. I did my fellowship in sexual medicine and male fertility here at UCLA. I did my residency training at the University of Michigan, and a long list of things here on this slide, but today I'm, of course, going to be focusing on erectile dysfunction and advanced erectile dysfunction as a key portion of my practice and what I did my fellowship training in. This is a reminder and a disclaimer that while this was organized and sponsored by Coloplast, I am volunteering my time to ensure that there's some educational content, and because I'm personally passionate about managing erectile dysfunction and actually think there are some public health implications. We actually are bringing some patients into healthcare to get their other comorbid conditions managed because they're showing up to either their primary care doctors or their urologist's office for the first time with ED. And so just an important backdrop and a reason that this is becoming more prevalent and more people like me are doing fellowships to help treat patients with advanced erectile dysfunction. There's a shortage of physicians in the United States, and this particularly impacts primary care. By 2032, there could be a shortage of up to 55,000 primary care doctors, and that's driven by a number of things. Number one, we have an aging population in the United States. The number of patients 65 and older just continues to go up and up and up. And as you can see from that second figure there, that's the same population that has more chronic conditions. And what types of chronic conditions? Well, we have hypertension, high cholesterol, coronary artery disease, diabetes, metabolic syndrome, the opioid epidemic. So many of these things continue to grow and impact all of your patients, all of my patients. And importantly, all these things can kind of come together and work against men in terms of their erectile dysfunction. Here are some of the numbers or the percentages of patients that will have this kind of bucket of medical comorbidities and what percentage of them are actually associated with comorbid ED. So patients who have vascular issues, cardiovascular disease, peripheral vascular disease, to 62% of them will have erectile dysfunction. 62% of those with hypertension, those of course are linked. Patients who've had pelvic trauma, things that urologists do, prostatectomy or a cystectomy, removing the whole bladder for cancer, very directly associated with increasing the risk of erectile dysfunction. And impressively, that number of diabetes, 78% of diabetic patients will have ED. And they may have it even earlier in life. And again, metabolic syndrome will tie into many of these things altogether. The vast majority, 80% of cases of erectile dysfunction, it is a organic or physical problem. So there's either a problem with blood flow, with the nerve signaling, or hormones, but there's something that medically can be done to kind of optimize that function for the patient. And importantly for me, something that I do all the time is if a patient is presenting for the first time with ED, I actually take a moment to evaluate these different categories because not surprisingly, many men, particularly in their 40s, 50s, may not have seen a primary care doctor ever, or at least in 3, 5, 10 years. So I use these visits as an opportunity to also check things like lipid panels, their blood pressure, their hemoglobin A1Cs. And in the last year and a half, it's been very satisfying to be able to place in referrals as a urologist for a patient to get established with primary care doctors because they're coming in for their ED, but then we actually find all these comorbid conditions that are certainly contributing. And importantly, it's a condition that's extremely common, but very treatable. So up to 50 million men in the United States suffer from erectile dysfunction. 40% of men by the age of 40 are affected by ED. And importantly, from that reference, actually, we see that that number keeps increasing every 10 years. So I tell my patients 50% of men by age 50 have ED, 60 by age 60. And that number really seems to correlate over the course of a man's lifespan. That helps provide some context. It helps highlight, too, how common this condition is, but how taboo of a subject it is, and that it really isn't talked about much in society. It's improving, but it's still something that requires a little bit of inquiring from doctors and advanced practice providers to make sure that if a patient is starting to have any of these issues, that they can be addressed. And why do I also think it's very important, in addition to this public health aspect, this mission of making sure that patients are just plugged into their primary care to improve overall health? Well, 50% of men will say that erectile dysfunction negatively impacts their day-to-day life. 84% say that it lowers their self-confidence. That sense of self, of feeling like who they truly are, really starts to get impacted once they feel that they can't function sexually and those intimate episodes with their partners are affected. And some studies have even reported that ED can increase the risk of depression. And why, thank you all for being here. Why is it so important to connect with primary care doctors, advanced practice providers, those of you who are truly at the front lines of healthcare in the United States? Well, you're really the first line of treatments and of access in many, many cases. 69% of patients first consult with their general practitioner or PCP for erectile dysfunction treatments. And about half of those patients feel negative emotions. They might feel ashamed, embarrassed, disappointed, humiliated, or sometimes even frustrated, angry that they're not being asked about and that the burden is on them to reach out and ask for help. And in some of these studies, primary care providers have also been shown to be the most influential resource for patients seeking treatments. Not only can you be a guiding light in terms of what can be done next and reaffirm and provide some context as to how common the condition is, but you're also the gatekeepers in terms of being able to access advanced and specialty care. So I'm just going to take a very brief moment. I know you're extremely busy. You often are seeing people for 4, 5, 6 different issues that they're coming in for that day. But I do like to hint and talk about the American Urologic Association recommendations for the ED diagnosis. Step 1 is very obvious, like everything else that I do, that you do in the clinic. It's a history, medical history, sexual history, psychosocial history, and the physical examination. Though truthfully, I think the physical examination does not add much to the initial evaluation of a patient who presents with erectile dysfunction. In fact, now I'm doing many of these visits as telehealth visits to ensure that patients from all over the area, all over Southern California, can get in and get access to this type of care. I do think laboratory testing is important. Number 1 is we can look at hormones. So many of these men, particularly later in life, if they have metabolic syndrome, they have diabetes, they're more likely to have low testosterone or testosterone deficiency. So that is one of the things that I'll often have checked for patients. But then, like I mentioned, especially if they haven't seen a primary care provider or a general practitioner recently, I'll also check prediabetes levels, lipid levels, and make sure we document the blood pressure during that encounter. When possible, when the workflows in your clinic and in your systems allow, having some validated questionnaires that patients can fill out can be really helpful. It helps capture that patient that may not yet feel comfortable themselves saying to you, hey doc, I'm suffering from this. I've been struggling with ED, or I've noticed changes in my erectile function. They may not know when the right time is to bring that up. And so these validated questionnaires, things that they can fill up on a piece of paper or through the patient portal, depending on your system, can allow for that to be captured. And if those numbers are abnormal, depending on comfort levels, some folks are able to address it immediately and provide a script for Viagra or Cialis. But other people say, look, hey, this is concerning, and I know, who I can send you to who's an expert in this area, and I would be happy to be that resource for all of you all. And certainly, if there's risk factors for cardiovascular disease, that's a very important part of the primary care or overall health evaluation. And what are the treatment options? And these are the many, many things that I talk about. But the primary bucket that most patients get exposed to even before they see me are the PDE5 inhibitors. So these are things like sildenafil or Viagra, tadalafil or Cialis, And these are the oral medications that most of the time are used about an hour or so prior to sexual activity to help improve the rigidity and maintenance of the erection. But when that fails or when that's not sufficient for satisfactory sexual activity, it is important to know that you have resources in your area that can talk about this plethora of other options. Penile injections can allow for medication at higher doses to be placed directly into the penis that have very high satisfaction rate in terms of achieving a rigid erection that is maintained, but there's some challenges there. There's only one formulation that is occasionally covered by insurance. Most of these injection medications come from compound pharmacies that have some added costs. And then, of course, for some patients, depending on their dexterity, how comfortable they feel with injections after an initial teaching, it may or may not be a sustainable option. Vacuum erection devices are a great tool, non-pharmacological, low risk of side effects other than maybe bruising or discomfort in the area of use. But again, they can feel kind of clumsy for some patients and some couples. And so it's really kind of trial and error for some of these other agents to see what's going to work. In the past, intraurethral alprostadil and nowadays compounded alprostadil type gels have been options for patients to help improve their erectile function. But similarly, cost tends to be a huge barrier to accessing these. And they have some other side effects. It can burn in the urethra when it's being instilled. And one of the compound pharmacies that is most widely used across the country, the cost of using one of these sources is, I think, $25 or $50 per use. So you can imagine that cost really adds up quite quickly. And finally, there's the gold standard for advanced or severe erectile dysfunction, and that's the penile implant. And of course, we're going to be talking a little bit more about that. There are some investigational therapies out there, and I'm sure you've heard or have seen patients talk about these. Shockwave therapy is using a device that sends energy that's focused into an area of the penis to try to create micro trauma that in theory in the lab seems to cause regeneration of new blood vessels. In many ways, actually the guidelines have recently been updated to change from experimental to investigational. The challenge is that cost is a significant barrier to patients. So no insurance is covering the cost of these shockwave treatments. There is some better and improved data, including a randomized control trial that shows that for mild ED, it can work. But for patients who are failing pills, it's not really a great option, and cost tends to be the biggest barrier. The PRP, platelet-rich plasma injections, and stem cell therapies over and over and over again have not been shown to be beneficial. A randomized control trial out of Miami recently showed that while they're safe, they do not seem to improve erectile function. And really, these are approaches that are often used by non-urologists, non-experts in the field, and folks who are using it to charge patients cash and essentially make money for their practice. Typical patient ED pathways is they'll go through oral medications, they'll progress to injections, and whether because of failure of the injections or just the logistics associated with drawing up a medication, etc., most men who are still sexually active and prioritize sexual function will progress to the penile implant. And so just to give you some numbers, some context, 75% of patients start with pills as a first-line therapy, but about 50% actually discontinue due to medication failure, no longer achieving the same response as before. And interestingly, that doesn't seem to be a tolerance, but rather just the aging process in the male body continues to get worse over time. Cost, huge reason that even now, while insurance companies will cover some tablets each month, cost tends to be a huge barrier, and I have ways to get around that in my practice. And then, of course, there's concerns about side effects or long-term safety. Oral medications can sometimes be second-line therapy. They'll use a different, 77% of patients will actually switch from Cialis to Viagra, for example. So they'll switch to a different type of oral medication. But in 40% of cases, in general, just pills are not going to be effective. There's been too many changes in the anatomy and the physiology of the body for pills alone to achieve an erection. 20% of patients will undergo treatments with penile injections. So they'll move from pills to the injections. These are folks who are often coming from their GP, PCP, advanced practice providers, and get referred to see a urologist to arrange these sorts of treatments. And in 30% of cases, unfortunately, injections either fail to work or men experience side effects, such as priapism, an erection lasting more than 4 hours that becomes uncomfortable, scary, concerning, and then that results in failure of continuing the treatment. And thankfully, once pills and injections no longer work, there has been a solution. There's an excellent solution in the market now, which is now the penile implant. And some patients, depending on their background, have they had previous surgery, et cetera, may move to this right away. And there's inflatable devices like you're seeing here on the screen, the Titan Touch, which has excellent patient satisfaction. And there's also some malleable devices for patients where they might have a hard time pumping up the device. And the penile implants really are able to put this hardware, this equipment, inside natural spaces of the body. So those cylinders go inside the corpora of the penis where blood flow used to fill. That reservoir, that balloon, holds sterile fluid that is able to travel from the cylinders back to that balloon. That's hidden behind the pubic bone or sometimes under the rectus muscle so that it's rarely ever felt or seen. And then that pump is in the scrotum, and it gives the man control over when they get an erection, and they can inflate and deflate the device under their own control. Importantly, most men are able to go home either the same day or just the next morning after the procedure. And then usually by 4 to 6 weeks, once they've healed, incisions are closed, the absorbable stitches have dissolved, and they're not having any achiness or discomfort down in the area, they're able to learn how to pump up, cycle the device, inflate it, deflate it, and they do that in our clinic with me, with my partners, to be able to make sure that they can use this device at home for satisfactory sexual activity. Of course, the benefits are you remove the hassle of timing pills, you remove the hassle of buying needles, syringes, dealing with a medication that has to be refrigerated. It is a long-term ED solution. Most of the studies suggest that the average life, once it's in the patient's body, can be up to 15 to 20 years. And it puts the man back in control of when they can get an erection, when they can have intimacy with their partners. And in many studies, it's been shown to restore the sense of spontaneity, the sense of confidence, and kind of feeling whole again. The patient satisfaction numbers with the Titan penile implant made by Coloplast are in the 98% range. And importantly, they've partnered with excellent researchers throughout the sexual medicine world to not only ask the patient perspective, but what do partners think? And the partner satisfaction is as high as 96% when these devices are used. So it's a long-term treatment under the patient's control, most often covered by insurance as an upfront approval that is done, and it results in long-term high patient satisfaction. Importantly and interestingly, when we're thinking about the healthcare system, a growing population, the cost of U.S. healthcare, which often get brought up in health policy conversations, it's actually the most cost-effective treatment over a 10-year period. So when we've analyzed some of the costs, out-of-pocket costs for typical ED treatment pathways, the oral medications, oftentimes there's deductibles, copays, only a small subset of pills will be accessible through insurance, and so patients are buying additional medications. That can rack up to over $9,000 in a 10-year period. Similarly, when we're looking at injections, even if we just take into account a year of injections and 3 years of using oral medications, that is over $10,000, almost $11,000. But when we look at the penile implant in 4 years of oral medications and a patient who transitions to the penile implant in year 5, because of the insurance coverage, because of the long-term reliability, we see that that cost really jumps down and drops off for the healthcare system. And when it's covered by insurance, it certainly is a cost saving directly for the patient. And so what can you do, as folks who are really at the front line of taking care of patients and addressing these number of chronic conditions? Well, number one is you can initiate the conversation. Sometimes you get a sense that the patient has something else to say and they're not quite feeling comfortable yet. I think questions as easy and as simple as, how are your erections? Are you satisfied with your erections? When the time is right, as you get to know your patients, can be a very easy way to initiate that conversation. And truly, they build great trust and rapport between a provider and the patient by asking those questions, because they get a sense that you care about them as a whole person and not just these small subsets of their health or of their persona. Like I said, when workflows allow it, using some sort of diagnostics tool, a standardized system like the Sexual Health Inventory for Men, these can allow patients to either on paper or through the patient portal fill out, and if those numbers categorize them as having erectile dysfunction, that can help capture these folks who may be living with ED but not feeling comfortable enough yet to address it or bring it up with their primary care doctor. Certainly, I want to empower you and thank you for all the times that you take care of patients with ED and provide either Viagra, Cialis, help alternate between medications, And so treating when it's appropriate, when they don't have contraindications like nitroglycerin, is such an important first step. But please monitor. If the pills are failing, then we're going to have to talk about other treatment options. And so that's when getting connected to a urologist, someone like me in the community, who's able to offer injections, talk about vacuum devices, and talk about the penile implant device, can be a fantastic opportunity for patients. And like I said, also to keep them engaged with their own health, using their penile function, their erectile function, as a way to encourage patients to work on their blood pressure, to work on their blood sugar control, to work on managing their weight and exercising and incorporating some healthy eating habits. It's incredible how many men are not afraid of a heart attack or a stroke, but when their erectile function starts to suffer, that can be quite a motivating event. And importantly, not all urologists specialize in ED. So finding the right urologist, finding someone who's a men's sexual health expert, someone who's completed a fellowship training like me, can make this more straightforward and more streamlined for your patients. That way they're not going to you, to a local urologist, and then having to bounce to a third person if they have to talk about advanced options like injections or the penile implant surgery. So, as a urologist with this background, as I mentioned, we not only do a full comprehensive evaluation and diagnostic workup, we address their other comorbid conditions and make sure that those are being discussed and talked about, and kind of working in conjunction with our primary care colleagues. But we also set patients up on a pathway. If they're on pills or starting to fail pills, we can do combination therapy through compound pharmacies that offer discounts to where they can be on a daily dose of a medication, take additional medication. But again, we go from orals to injections to, when the right time strikes, the penile implant device. And I always try to make sure to send a note back to the providers who refer me these patients. And, first of all, thank you for sending them to the right person. But number two, giving you an update, letting you know how things are going and how we're progressing along the pathway. So here, please take a moment to take a screenshot of the slide. This talk is also being recorded and is going to be disseminated back to you, so you're going to have it as a resource. But that's my personal contact information. That's my work-related cell phone. I truly mean it. If you have a patient that falls into this category, they're struggling to figure out where to go to get the advanced level of care, please do not hesitate to shoot me an email or send a text message or call me at that phone number. That is my direct line, UCLA cell phone. But here's also the information for the two clinics that I practice out of, both at Santa Monica and Westwood. That's my website and our clinic scheduling line, as well as every Monday I'm down at the MLK Wilmington Clinic, where we're building a men's health center in addition to addressing the general urology needs like elevated PSA, hematuria, things like this. And then that is a QR code from Coloplast Company themselves, and that can provide you a link to a resource website where there's information for providers, information for patients, and importantly, as someone who's a native Spanish speaker, that exists both in English and Spanish. At the MLK Community Clinic, I'm seeing 75% of patients who are Spanish speaking, and they're surprised that there's finally someone in South LA addressing these issues and these concerns. So thank you so much for your time and for your attention today.